Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 106, Trigeminal Neuralgia and MS, an Invisible Challenge. Interview with Dr. Monika Köchling. This time I'm talking to Dr. Monika Köchling about the causes and treatment options for trigeminal neuralgia. Since this form of facial pain can lead to extreme restrictions in the quality of life, it is extremely important to treat it. The good news is that there are many approaches to controlling the pain or even getting rid of it completely. However, this can sometimes take a little longer, and it is important to work with your doctors to find a solution and possibly try several approaches. By the way, the original interview was in German, and I adapted it for the international MS community, so I speak both parts. But as it is one of the absolute favorites in German, I think you will appreciate it as well. So let's start with a short introduction of Dr. Monika Köchling. Monika, would you please be so kind and introduce yourself to the audience? Sure, Nele. I work in Grevenbroich, Germany, as a neurologist, psychiatrist and psychotherapist in a large group practice, the NeuroCentrum am Rheinlandklinikum. I live in Düsseldorf and I'm married for the second time. I also have 2 grown-up sons. My hobbies include singing in a choir, hiking and poetry. Monika, what was your personal motivation for the job? For me, it is definitely curiosity that repeatedly drives me to the right things. I did my doctorate in the neurological department of Professor Dr. Med. Klaus Poig, which influenced my choice of neurology. It is fascinating to see how people cope with their personal challenges. I still learn a lot from my patients, because in neurology and psychiatry, it is often necessary to integrate coping with an illness into life. Thanks to many years of experience, I can give 1 or 2 impulses for doing this well. I'm motivated to keep finding out what I can contribute to giving this person sitting across from me something useful. Since it is impossible to keep track of everything, I love being able to work as part of a large team with 10 specialist colleagues, neurologists and psychiatrists, and psychotherapists, as well as pain therapists, and 3 psychological colleagues and a large team of MFAs, including MS nurses. I'm also an active member of the advisory board of the Neurotrends Data Network, which works with practices and colleagues to compile valuable real-world experience data using DESTINY, which is an abbreviation for Database Assisted Therapy Decision Support System, and to answer questions together in projects in order to optimize therapy and disease management. To do this, we also use FRIEND, predictive healthcare with real-world evidence for neurological disorders, as a therapy optimization module. Okay, Monika, thank you. Let's start with the basics of trigeminal neuralgia in MS. What is trigeminal neuralgia and how can it manifest itself in people with multiple sclerosis? Good question, Nele. Trigeminal neuralgia is one of the most painful disorders, with typical facial pain that is limited to the area supplied by the trigeminal nerve. The pain attacks are particularly severe, characterized by sudden shooting sensations that last only seconds, but in severe cases can occur in serious and last up to 2 minutes. These pain attacks are relatively uniform and repetitive. In addition to touching the skin in the affected parts of the face, even a draft of air can trigger the pain attacks, as can speaking, eating, and drinking. In severe cases, there is a restriction in the intake of food and fluids, as well as a significant reduction in quality of life and ability to participate. The trigeminal nerve follows a path after a switchover station, the ganglion gasseri, with 3 nerve branches, which provide sensitive supply to the forehead, the area of the upper jaw, and the area of the lower jaw. These nerve branches are designated as branches 1, 2, and 3 of the 5th cranial nerve Roman V. Typically, trigeminal neuralgia occurs much more frequently in the area of branches 2 and 3, i.e. in the area of the upper and lower jaw. Okay, thank you, Monika. How common is trigeminal neuralgia in people with MS, and does the likelihood increases with the duration of the disease? That's a good question, Nele. 2 or 5% of patients with MS suffer from trigeminal neuralgia at some point. In addition, those affected develop the condition at a younger age, below 40 years. Normally, trigeminal neuralgia primarily affects older people, and women are more likely to develop it than men, with a prevalence of 0.16 to 0.30%. The probability of occurrence depends on the course of the MS. Trigeminal neuralgia in MS patients is based on an inflammatory focus in the root area of the trigeminal nerve in the brainstem, level of the pons. In half of the affected MS patients, there is also a neurovascular contact, the dual hit theory. Okay, thank you. Monika, how is trigeminal neuralgia diagnosed and differentiated from other facial pain? Yes, Nele, the clinical diagnostic criteria of the International Classification of Headache Disorders, the ICHD, are important. These include, number 1, recurrent paroxysmal unilateral facial pain attacks in the area supplied by 1 or more branches of the trigeminal nerve with no radiation beyond this area. Number 2, the pain has all of the following characteristics: duration of seconds to 2 minutes, severe intensity, and electric shock-like shooting, stabbing, or sharp quality. Number 3, triggered by non-noxious stimuli in the affected area supplied by the trigeminal nerve. And number 4, not better explained by another ICHD diagnosis. The decisive factor in classic trigeminal neuralgia is that the neurological findings are unremarkable, except for a slight sensory disturbance in the affected area of the face and hypersensitive nerve exit points of the nerve parts in the face. Other facial pains may present with a similar distribution, but are usually permanent with fewer lightning-like attacks. There are also differential diagnoses. There is peripheral trigeminal neuralgia, which is mostly continuous burning pain and additional attacks, e.g. post-herpetic neuralgia. There might be collagenous such as Sjögren's syndrome, or traumatic damage or tumors in the area of the trigeminal nerve. Involvent ENT specialists and dentists are diagnosed for diagnostics. Typical case history and electrophysiological evidence of trigeminal nerve damage with certain electrophysiological examinations, blink reflex and TRIG-SSEP. Another differential diagnosis might be the persistent idiopathic facial pain, formerly atypical facial pain. This is defined by a continuous, usually dull, deep-seated pain without sharp boundaries, often beginning in the area and spreading diffusely over time, and can also radiate to the opposite side. No intense shooting attacks, often triggered by painful events, e.g. dental treatment. It might be electricity-like attacks in the first branch of the trigeminal nerve. Differentiation of trigeminal neuralgia from SUNCT, short-lasting unilateral neuralgiform headache, attacks with conjunctival injection and tearing. Or SUNA, SUNA, short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. Both are rare trigeminal autonomic headache disorders with short unilateral pain attacks in the forehead and eye that are accompanied by ipsilateral trigeminal autonomic symptoms such as tearing and redness of the eye. And sorry, I'm not laughing because it's funny. It's just not so easy for me to pronounce it all correctly in English. So sorry for that. I hope you can follow me. Okay, classic trigeminal neuralgia with compression by a vessel, atrophy or displacement. Neurovascular contact or conflict between a vessel, superior or posterior inferior cerebellar artery, and the cisternal portion of the trigeminal nerve, or an embryological variant by trigeminal artery primitiva, a branch of the internal carotid artery at the level of the Meckel's cave, or a cardiobasilar anastomosis. The diagnosis is made by magnetic resonance imaging, so MRI, of the cisternal cranial nerves. In a T2-weighted sequence with millimeter range resolution, constructive interference in steady state, CISS, or sampling perfection with application optimized contrast using different flip angle evolutions, SPACE, or fast imaging employing steady acquisition, FIESTA, or balance fast field echo, FEE. Additional vascular imaging using three-dimensional time of flight technology, which is helpful for visualizing the contact. The cisternal veins, especially the superior and inferior petrosal sinus draining veins, can also cause the relevant contact. And I'm sure you don't need to remember that or take this information to your doctor. Your doctor will know it is just something. If you want to ask, I don't know, one of the AIs or something like that, it might be helpful to have that information. Okay, what is an important secondary cause or secondary causes? MS lesions in entry zones and tumor in the entry zone, intrinsic tumors such as schwannomas, neurinomas, extrinsic compressing tumors such as cysternous meningiomas of the tentorium. Thank you, Monika. Let's come to the treatment options of trigeminal neuralgia in MS. What treatment options are available for trigeminal neuralgia in MS, and how are these customized? Thank you, Nele. That is a very important question, and I'm sure your listeners are very interested in this. So there is no efficacy of direct-acting painkillers, e.g. NSAIDs, seizure-suppressing medications, formerly called anticonvulsants, are used. So the drug treatment of trigeminal neuralgia includes a basic therapy with carbamazepine 200 to 1,200 mg, oxcarbazepine 300 to 1,800 mg. For advanced cases, pregabalin 150 to 600 mg. Gabapentin 900 to 3,000 mg, Baclofen 25 to 75 mg, Lamotrigine 200 to 400 mg, phenytoin according to serum level, misoprostol 600 g, botulinum toxin or nabotulinum A 25 to 100 U. For treatment of acute exacerbation, phenytoin 250 mg slow intravenous. Pymoside 4 to 12 mg. Series of ganglionic local opioid analgesia at the cervical superior ganglion. Sumatriptan 6 mg SC or 100 mg orally in 2 doses. If medical therapy fails, the decision is made to proceed with neurosurgical treatment. Microvascular decompression, surgical procedure according to Janet. Percutaneous procedures. Radiofrequency thermocoagulation, glycerol resolysis, balloon compression, radiosurgery. And please again take into account that this is something you need to discuss with your neurologist, and of course your neurologist will know better, and it's just to get an idea what type of medication or type of treatment is used, but you don't need to remember that exactly. And if you want to do that, you can look at the blog article as well, which you find a link in the show notes too. So Monika, thanks for that. Let's move on. What non-drug approaches can help to alleviate the symptoms of trigeminal neuralgia? Yes, Nele, that's important. Non-pharmacological approaches to therapy alone are not sufficiently helpful. That's something you really need to keep in mind. Sufficient pain management strategies can be used to support this, such as relaxation therapy, in particular progressive muscle relaxation, according to Jacobson, to acquire basic relaxation skills. Then there is, of course, stress management, occupational therapy, biofeedback therapy, a psychotherapy method that is sometimes also offered by occupational therapists, psychotherapy with a focus on pain psychotherapy, and if the pain becomes chronic, participating in an inpatient or daycare multimodal pain therapy program can also be helpful and may contribute to establishment of successful pain management. Monika, what role do accompanying therapies such as physiotherapy or relaxation techniques play in coping with pain? They are very helpful in regulating muscle tone, e.g. specialized physiotherapy or craniomandibular dysfunction, CMD for short. Okay, and Monika, are there any promising new developments or therapeutic approaches for patients with trigeminal neuralgia? Yes, Nele, the further development of seizure-suppressing medication, in particular sodium channel blockers, which do not require an updosing phase and offer a favorable side effect profile, e.g. visotrigine. Okay, let's move on to the effects of trigeminal neuralgia in MS. How does trigeminal neuralgia affect the general well-being and quality of life of MS patients? Good point, Nele. Trigeminal neuralgia can lead to a significant reduction in quality of life. It often restricts the ability to participate, even to the point of being unable to work regularly. Those affected have a higher risk of developing comorbid depressive phases of illness. Okay, and what are the long-term prospects for MS patients with trigeminal neuralgia, and how can the prognosis be improved? Nele, there is often a risk of chronification and a high risk of recurrence, depending on the cause and treatment options. Neurosurgical measures, in particular, can provide relief. Okay, thank you, Monika. What is the best way to prevent trigeminal neuralgia, if it is possible at all? Nele, unfortunately, there are no specific factors, or maybe it's good. The trigeminal nerve is susceptible to transient reactive symptoms after viral infections. So everything that keeps us immunologically robust, such as a healthy diet, sufficient exercise, regenerative sleep, and no stress escalation have a preventive effect. Okay, Monika, thank you. So we are nearly at the end of our interview. Let's move on to the Quickfire Q&A sessions. Complete the sentence. For me, multiple sclerosis is a challenge for patients and doctors. Okay. What breakthrough in MS research and treatment would you like to see in the next 5 years? I would like to see medication with an optimal side effect profile and improved disease management services, such as psychoeducation. Finally, what is the most important message you would like to give to MS patients with trigeminal neuralgia? Yes, Nele, attitude is crucial. Don't despair. Become and remain resilient and dare to try new things. To quote Hilde Domen, I put my foot in the air and it carried me. Okay, thank you very much, Monika, for this insight, for this really in-depth insight. And to you out there, I hope you get really a good treatment, and please try different things if it doesn't work at the first time, and try to get rid of this horrible pain if you have it. So please remember, stay as healthy and positive as possible, and see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast, perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.